Luscious. Yes, that's right. Yes, I'm luscious. I'm luscious, and I'll sure be good to you. They used to call me Fish, but now they call me Lou. When I make my music, I started with a rule. I took a little song and then it begins to smoke. I picked this trombone up and then I played it till it broke. 'Cause I'm luscious. That's right, yes, I'm luscious. I'm luscious, and I'll sure be good to you.
We're unfortunately losing him. They want us to go? Oh yeah, we're on. We're live.
All right, I think we have a strict time to start today, so we're going to begin. But for those of you online to get lunch, please go ahead and get your lunch and find yourself a seat today. So on behalf of MLI, I want to thank you for attending this symposium entitled Elevating Myelofibrosis Care Strategies for Risk Assessment, Treatment Innovations, and Care Excellence. This activity is supported by independent medical education grants from BMS, Geron, and Insight Corporation. We want to thank them for their support. I'm John Mascarenhas from Mount Sinai, New York City, and I'm really pleased to be joined by a close colleague and friend, Aaron Gerds.
Well, thank you very much. Thanks everyone for coming, and thank you, John, for that kind introduction. My name is Aaron Gerds. I am at the Cleveland Clinic. And before we get started, a couple housekeeping messages. There are sheets of paper and cards at your table. The first thing, you thought this was going to be easy, you just come and get lunch, but really there's going to be a lot of work for you today. There is a pre-test, there is a post-test. So you fill out the pre-test before, not after, and the post-test after. That way we know you learned something today. And there is an evaluation, so we take both positive and hopefully only positive, but if you got some critical feedback for us as well, we will take that. So these sheets are all at your table. Also at your table are two cards. One card is got a QR code, so you can collect your CME credit, and on the back are your key takeaways from today's presentation. The other card looks like this, and this is for questions as we go along. We really want this to be an open dialogue, not just between the two of us. We talk all the time. I think I've heard almost everything John has to say, and then some. But we want to hear from you too. So put down your questions for us on this card and hold it up in the air. Someone from the MLI will come by and grab that and then bring that up here. There's also an app you can log on and submit your questions electronically. Like you guys make this session successful, so please participate. So as I mentioned today, we will engage in a dialogue format, having a candid conversation approach as we explore and apply validated risk stratification tools and scoring systems to individualize treatment strategies for patients with myelofibrosis. We will assess the mechanisms of action and efficacy and safety data for current and emerging therapies for myelofibrosis. We will design optimal individualized treatment plans for myelofibrosis based on the latest clinical evidence and facilitate multidisciplinary care and collaboration in the comprehensive management of myelofibrosis. So thanks again for joining us today, and let's get started.
All right, excellent. Thanks, Aaron. So I just want to re-emphasize one more point, or one more thing again. If you haven't already done it, please download the Soho 365 mobile app, because that's actually how you can answer these audience response questions, which we really would encourage you to do, and it helps us understand where we're coming from and where we're going, and whether we've succeeded in our objectives as outlined by Aaron. So with that, we will start. That's us. We introduced ourselves. Here are our disclosures. And Aaron nicely went through the learning objectives, which are outlined here. And here's our agenda. We're going to go through the prognostic risk and symptom burden assessment in MF, then current and emerging treatment options, and then lastly, the role of a multidisciplinary team. And then hopefully at the end, we'll have time for questions and answers. And if we don't, I'm sure Aaron, as well as myself, will have time. If anyone has any burning questions, we can linger on and go over them. So here's the first polling question. So this is where we really need your participation. Which of the following best reflects how you monitor symptom burden in patients with MF? A, I routinely use tools like the MPN-SAF TSS. B, I rely on informal discussions with patients. C, I focus primarily on lab or imaging results. D, I monitor symptoms only during the therapy changes. Or E, I am not familiar with standardized tools. And there is no right or wrong answer. Please give us your best response to this polling question. Usually we have like a little. Oh, there we go.
Number.
There we go. Well, they're up there.
Oh, there you are.
All right. So about half the participants today do routinely use the tools like the MPN-SAF. And we're gonna. Our goal here is to poll these questions, and we're gonna sort of break into discussions about them. But also the slides we're gonna cover speak to these questions as well. Excellent. So the first thing is listening to patients. And here's a quote directly taken from online from a patient listserv. There are continual developments with MF and medications, so try to get linked in with a university that researches MPN or cancers. I'm doing well, but the fatigue and bone pain are there. Being sick also gave me some mental health issues, so I see a therapist. Now I know, Aaron, you see a therapist, you can probably really relate to this, and this is an issue that many patients of ours have. And there's three things from this quote that I think resonate with me, which is when you have a rare disease, I think it is important when you're in the community to at least at some opportunity have a consultation with someone who really focuses in on these areas like Aaron and I do. And that may not be the person who primarily takes care of you, but ideally there's a shared care model where you can work with the physician in the community. And patients with rare diseases obviously feel isolated often because they don't have a disease that other patients or people in their family can relate to, and that makes it difficult, I think, from a psychosocial perspective. So I don't know if you have any thoughts about this quote that you want to cover.
Yeah, I think the big thing here is it's a chronic illness, right? Often MPNs, we think of it as a chronic leukemia, chronic illness, and just having that burden of every day I wake up and I look in the mirror and I see a reflection of someone who has cancer, and doing that not for a day, not for 2 days, but for years and decades. And I think it really weighs heavily on patients. There's old data saying that patients have a diagnosed psychiatric disturbance, and roughly 30% of patients with MPNs will have a diagnosed psychiatric issue, and there's probably a lot that go undiagnosed. So it's a real thing.
And the other part that I think is missed sometimes is that MPNs are cancers. They are neoplasms. And it's not infrequent that I'll see a patient in a cancer center. I'm an oncologist. And I will make reference to the fact that these are hematopoietic stem cell malignancies. These are cancers of the blood. And the patient nearly falls off their chair because they actually haven't heard that before. They thought it was simply a disorder, which I think is a disservice, actually, to the disease and to the management and treatment of these diseases. So I think probably a lot of people in the room are aware that there are WHO diagnostic criteria for every disease that we treat, but specifically here, these are for primary MF, in which there are major criteria shown on top, which involve a bone marrow biopsy. And one of the most frustrating things is when I see a patient who's actually never had a bone marrow biopsy, but is labeled as myelofibrosis. And as you can imagine, there are multiple competing diagnoses, including MDS with fibrosis and other diseases that can have fibrosis in the bone marrow. So fibrosis in the bone marrow itself doesn't give you the diagnosis of primary myelofibrosis. You need to rule out having ET, PV, CML with BCR-ABL, and then ideally have a clonal marker of a disease, such as JAK2, MPL, or CALR, or a chromosomal abnormality that meets those criteria. And then invariably, MF patients have anemia. If not at presentation, in which most patients do, it will worsen with disease course. Leukocytosis, LDH, I think, is a poor man's test that really provides me with a lot of understanding of where they are in their disease course, because LDH is a marker of the proliferative capacity of the disease. Is almost always elevated and worsens with the disease course. And then, of course, the classic leukoerythroblastosis from a myelothesic process in the bone marrow. So all three major criteria and one minor criteria gives you the diagnosis of primary myelofibrosis. And there is a triad that we often think of with MF. It's the triad of cytopenias, systemic symptoms that are driven through inflammatory pathways, and then splenomegaly due to extramedullary hematopoiesis and aberrant stem cell trafficking. These patients really are quite ill, and as Aaron pointed out, they're quite symptomatic in many ways. They don't always look symptomatic, but they feel symptomatic, whether it's profound fatigue, bone pains, pruritus, muscle cramps at night, poor sleep, and inactivity, as well as spleen-related complaints that really impact quality of life and reduce functionality. And anemia is a major issue, as I've stressed in this disease. Both can be at presentation, but along the clinical course. That often ties patients to the transfusion suite, and Aaron and I did a symposium yesterday, really focused on the shared issues of anemia across the myeloid malignancy spectrum from MDS and MPN, the impact anemia has specifically, and the methodologies of trying to address anemia. So as I keep highlighting, there is a lot of quality of life issues that affect our patients with myelofibrosis. And the ones that are often taught in medical school are the thrombohemorrhagic, the vascular complications, which of course are more, I think probably more prominent, more focused on in ET and PV, but can also occur in MF. Abdominal vein thrombosis are often missed. Patients can have a big liver and big spleen. Sometimes it is solely due to extramedullary hematopoiesis, but the more you scan patients, the more you realize that they've had undiagnosed portal vein thrombosis or other splanchnic vein thromboses as well. The biggest fear for most of our patients is the dreaded complication of progression or evolution to acute myeloid leukemia, which happens in about 10 to 20% of patients with myelofibrosis within the first decade. And even in the absence of evolution to AML, the progression of underlying MF is a fatal disease with a median survival of 5 to 6 years. This is a very inflammatory disease. So again, the symptomatology we think is driven in large part by the cytokines that are routinely found to be elevated, whether it's IL-8, TNF-alpha, IL-6, IL-1 beta, that drive the cachexia, also contribute to anemia, and lead to brain fog. And that's actually a common complaint that's often, I think, overlooked or underappreciated, is patients will often tell you that they can't think straight, they don't have the same memory or ability to have the same cognitive capabilities as they did prior to the diagnosis. And that often gets minimized or not even really acknowledged. And then cytopenias are a major issue. Again, that tie patients to the transfusion suite, lead to bleeding risk, and also contribute to morbidity. I think one of the complications I always find very fascinating that I see pretty frequently, and if you look, you'll find it, is pulmonary issues associated with myelofibrosis, particularly pulmonary hypertension that can occur in about a third of the patients, and in sometimes frank extramedullary hematopoiesis in the lung, in which low-dose radiation can sometimes be used. So the organ dysfunction, renal insufficiency, liver dysfunction are all issues. So it's really a systemic disease in which we tend to focus on the blood counts, but multiple organs are affected. And of course, the host is probably the most important aspect of figuring out how to manage a patient, the patient's age, the competing comorbidities, the psychological aspects of treatment, drug-drug interactions, and then nutritional status. With splenomegaly, and early satiety and cachexia, many of these patients are probably not getting adequate nutrition and would benefit from a nutrition consult. There's a lot of data, and we're not going to go through it in specifics, demonstrating that there is a significant symptom burden that's really been well characterized by Ruben Mesa and colleagues, in which if you ask what is probably the most prominent symptom and most severe symptom, it's fatigue. Mm-hmm. And Aaron can say some words on fatigue, which is not always the same thing as like I feel tired or I haven't slept well. Aaron, if you want to speak to that aspect.
You know, as the data here shows, that fatigue is the most common symptom. It's often the most severe symptom that patients will report, and it's incredibly challenging to treat, right? So fatigue is such a vague term, right? I'm just tired, right? But there is a true difference between like sleepiness and tiredness and fatigue. Fatigue, you can't get off the couch, you just don't have motivation. Where true tiredness is like, I'm sitting there watching TV and before the commercial break's over, I'm out. Or I pull up to a Floridian stoplight that seems to go on forever and I fall asleep before it turns green. So there are different things, right? And so they can take you down different paths. Fatigue might be disease related, but tiredness or sleepiness might be something like sleep apnea or something else. And the truth of the matter is fatigue is also multifactorial. We just talked about how many patients experience depression or anxiety surrounding their diagnosis, and that can feed into fatigue. Patients they're older, so they may be on blood pressure medicines that could affect their fatigue, or other medications. They may have other medical problems that are all added in to this conglomerate of just fatigue. And we'll see a little bit later that people who don't have MPNs have a lot of fatigue in general. And so is it just because they're human and it's part of the human experience, or is this truly being driven by the disease or the treatments for the disease? It makes it a real challenge for us to treat.
And I never noticed until this moment that the fatigue rating or prevalence was actually much higher in the US than internationally, which I think is an interesting observation in itself. Maybe moving from the US can improve your fatigue just in that itself. And then, of course, the impacts of MF on quality of life and employment, shouldn't be underscored as well. I see it all the time. There's significant reduction in quality of life Patients will routinely tell me that they cannot predict what their weekend will look like, how they will feel for that weekend, and what their weekend will look like. So it really makes it difficult to plan activities, family activities, or even work-related activities, which often result in having to call in sick. So I think we often don't appreciate the impact beyond the physical aspects of disease that really affect the quality of life and functionality and social behaviors of a lot of our patients as well. So the next polling question, number 2, when do you typically involve palliative or supportive care services for patients with MF? So A, at diagnosis as part of the initial clinical planning, B, only when symptoms become unmanageable, C, near end of life or hospice transition, D, rarely or never, or E, I'm just not sure when it's most appropriate. So please select the best answer for this polling question. Now, there's way more than 20 people in this room. I would love to see more participants participate in, and there's the QR code. So you can just scan the QR. I want everyone to do this right now. Please do me a favor. Scan that QR code and help us get that number way over 50 where it should be. Or 100 it should be, but at least over 50. There we go. Thank you, guys. So, at diagnosis, I don't know, Aaron, what do you think about that?
Well, kind of my take is it's like voting in Chicago, vote early, vote often, right? And so, I don't think it's ever a wrong time to call up your palliative medicine doc, your local, if you have one, and have access to that, to get them involved. These patients, they have a chronic but life-limiting illness, and it makes sense. And these patients are so symptomatic. We haven't even talked about treatment or side effects yet. We've just spent all this time talking about symptoms, let alone what the therapies might do to them. So I think it's really important and can help augment your care.
Excellent. And I appreciate that we now have 104 participants. That's great. Thank you. Okay, I'm going to hand it over to Aaron.
Thank you. Again, we've really focused on symptoms and how they disrupt quality of life. And again, this is a theme that's emerging here. And patients in these online chat forums will say, which symptoms have the greatest impact on it. We ask ourselves which symptoms have the greatest impact on their daily life, their well-being. You also mentioned like the work productivity and the interactions with the family. And we talk about the fear of progression. And I think really I like this question because we think about progression in so many different ways in myelofibrosis. We talk about blasts going up simply and accelerated in blast phase disease, but boy, can symptom progression be a thing, or spleen progression, or how do you really monitor that, John, and think about it in your everyday practice?
Yeah, so I definitely spend, and my team probably spends even more time than I do, going through symptomatology with patients. A lot of it's reassuring patients. And patients can absolutely have progressive, even on a good therapy like a JAK inhibitor that's addressing maybe their spleen, they can have breakthrough symptoms that then get worse. I think so being able to make sure the patient reports that, and some patients are good at that, some patients are bad at that. Some patients will, and what we ask patients is like, just report the symptoms. Don't filter it by what you think is relevant or what you think is MF related. Because patients will often say, well, I'm not going to report this because I don't really think it's MF. And then you let them know that it could be MF related and they're shocked by that. So I think making sure that patients are just transparent about their symptoms actually is the first step.
And we often in our practice think about that in the context of clinical trials, right? Because you have to have a certain symptom burden to get on a trial. I'm like, I just tell the patient, be honest about how you're feeling. It doesn't matter if you rate this a 3 or a 6, just be honest. Don't underestimate, don't be a tough guy. Be honest with your symptoms because it's important for monitoring. We really don't want to know how you feel.
And I think if you want to get an honest answer of how poorly someone's feeling, make sure their wife is in the room.
The spouse, you got a second eye on
the wife is there, you get a real good sense of what's going on because men cannot answer those questions.
No,
that's just unfortunate.
I'm fine, I'm stoic,
Yeah.
The other thing is the eyeball test, as I like to call it. So, I'll see a patient and a few months pass, I'll see them again, maybe a few more months pass, or maybe they don't come to see me in person because they do a virtual visit over the winter, with all the snow in Cleveland. And I see them and I'm like, wow, the eyeball test. You guys, the patient's faces changed, their appearance have changed. And that to me, they may report symptoms being the same, but they don't pass the eyeball test. And then we have to have a discussion like, is the treatment meeting your needs right now?
And I want to bring out an obvious point that I think is obvious, is that obviously we're interested in, and we keep stressing this whole issue of symptomatology. We think it's disease driven by inflammation. But it's also important because it actually triggers treatment decision making. So it's not simply to highlight, MF patients are symptomatic and that's a problem. It really is important and fundamental to the therapeutic management of patients with MF.
Now, we're going to talk about prognostic scales. This is different than a lot of other diseases where your prognosis dictates treatment. Here, it's purely, we talk about prognosis, it's important, but it's purely, is your spleen bothering you? Are your symptoms bothering you? Are your cytopenias bothering you? And if the answer to any of those questions are yes, you start treatment independent of disease risk. And on that note, we're going to pivot to some of these things, prognosis, that is. And one of the older, if you will, prognostic factors in myelofibrosis is anemia. Anemia is a really interesting one because I think it's a good representation of underlying biology of the disease and obviously closely connected with symptom burden as well. You expect an anemic patient may feel anemic and run down and have worse fatigue and worse functional status. And the really interesting thing about anemia too is it's not just a on-off, a 0 or a 1. It's a dose response curve. We often think about therapeutics like this. The higher the dose of the medicine, the better response. Anemia does the same thing for prognosis. The worse the anemia is, the worse the prognosis is. So it's a really good indicator of prognosis and something we really tend to focus on, not just, again, because of the clinical burden of anemia, but because of the prognostic relevance of it. And therefore, it's a big part of our scoring systems, whether we're talking DIPS, MIPS, GIPS, IPS, whatever other weird-sounding model we have. It's an important part, and despite having genomic information available, we can look at all the chromosomes and genes we want, anemia still remains as an important prognostic model, and so I think that a marker, and I think that's a really a point I'd like to emphasize often. But no matter what the model is we use, the models kind of take all these clinical factors, put disease into disease risk categories, and that helps us answer a couple questions. First of all, it helps us counsel a patient on what they may expect over the next year, 2 years, 5 years, et cetera. And I think these models are also really important to trying to understand what patients should we be talking about transplantation. The one therapy we have right now that can eradicate the disease long-term in these folks. So if you have a person who is otherwise healthy, has a high-risk disease, we're thinking about transplant for those patients. So I think, again, treatment decisions are based on spleen, symptoms, cytopenias, but prognostic models help for transplant referral and counseling. We also think about disease response now, and I think this is a really important slide. I know our friend and colleague Andrew Kuykendall loves this RR6, which they're working on revising the RR6, so it'll be the RRR6 or R3R6. But it's such a practical. I like it because it's so practical. You only have to remember 3 things, and I'm not very smart, so this is about all I can do. Is the patient on the full dose of ruxolitinib? Is the patient transfusion dependent or not? And is the patient enjoying a spleen response? And if you're answering yes to all those questions, you are getting the maximum benefit out of the treatment. You're on the right path, keep it up. But if at 3 months or 6 months, you're not hitting those critical endpoints with the treatment, it's time to think about something else. We're not really optimizing the care of those patients, not only for their quality of life, but also their survival as shown on the curve on the right. And with that, we're going to hear now from a patient and their experience.
As an MF patient, there is no typical day. At 9 a.m., my stamina may be great. Later that afternoon, I cannot feel my energy is totally gone. One day I can feel like I can do a great workout. The other day I'm feeling like I'm on the couch. Last Thursday, I'm playing ball with my grandson on the grass. 1 week later, I'm on the couch. A week ago, my hemoglobin was 8.1, which personally for me with myelofibrosis, that's a dream of being 8.1, if you can imagine that. This week, my hemoglobin dropped to 6.6, and I can't move. Even when my lab numbers suggest that I should just be laying on the couch, laying in bed. So it's just this desire to create internal energy and ignore the numbers. That's really what has helped me and driven me to overpower how I'm really feeling.
Excellent insight there from Sheldon. I think it really kind of is the definition of unmet need. So now we're gonna continue to focus on symptoms here a little bit. And I alluded to this earlier. We're gonna channel our inner Stanley. Think about put on our Spider-Man mask and look at the spiderweb plot. And really, this is an important study because it shows us 2 things. One is that patients with MPNs are symptomatic. So if you look at the spider plot here, there's the outer darker web, if you will, and there's the inner lighter gray web that has the red arrow pointing to it. So the outer web is the symptom burden of patients with MPNs, and the inner burden is that of the general population. So in fact, what the study was is they gave the MPN-10, the MPN symptom assessment score, to patients who both had MPNs and those who did not, and they compared the two. And you can see that, one, the general population has a lot of symptoms, fatigue, mood issues, walking issues, all these things, the symptoms are really present in the normal population. But certainly patients with MPN are much more symptomatic compared to the general population. So I think this is part of the challenge. We can make people feel better with some of the therapies that we have, but we can't make them not human. And what is due to the MPN, what is due to other things, is a really difficult challenge because these symptoms are not that precise. And I alluded to this the prior slide, the MPN-10 or MPN-SAF-TSS. This is the way we measure symptoms in MPNs. This is in the NCCN guidelines. It's used often. It's a little clunky, I'll admit. It's 10 questions on a scale of 0 to 10. It takes a few moments for the patients to fill out, but honestly, at this point, I've trained my patients pretty well. They know that this is coming. They know I'm going to ask them all these questions and all the answers on a scale of 0 to 10. I even have like a little chart with the smiley faces and the frowny faces to help guide the conversation. I know a lot of colleagues actually have their nurses do it before they even hit the room. So I do feel that this is a valuable tool to get that information of how a patient is feeling, and not only how they're feeling that day, but how compared to how they were feeling before and how they're feeling in the future. So I do find this a useful tool. Even if you just simplify it down to like, are you better, worse, or the same, or the patient global impression change, I think can be very valuable. Just get that conversation started, really focus in on those symptoms. Again, it's a major trigger for how patients are feeling, how their quality of life is, and how it might affect your treatment decisions going forward. So we're going to hear a little bit more from our discussion here and a few prompts. And of course, I will also want to take a moment to encourage your engagement with this presentation. Go ahead, write your questions down. Let us engage and talk about what we think is important in this and try to answer your questions. So go ahead and write your questions down on those little cards. We'll collect them and answer them or put them in online. But to get the conversation going, what practical barriers keep clinicians from incorporating risk scoring systems like DIPS or MIPS in their routine care? Certainly want to hear from you. Do you think current risk models capture what matters most to patients, or are they too focused on survival estimates? And how do you balance risk score outputs with clinical judgment, especially in patients with being discordant features like low risk but high risk symptom burden? John, I know you use models in your practice to understand prognosis, and we kind of talked about it a little bit earlier, but what do you think about these models? Are they helpful? Are they not helpful? Do you use them every day?
So we have a lot of models, more models than we have probably classes of therapies that we treat MF with, which is problematic. And the models are sort of designed to refine prognostication. But at the end of the day, you said it very nicely, at the end of the day, the models really help us in one regard at this point, which is go, no go for transplant. I think that's really the beauty of the models. And there are models that are transplant-specific models, like the MTSS, but they don't really capture, I think, the main reason why we intervene for most patients up front, which is really symptom burden, splenomegaly, and increasingly cytopenia. So the models have their role. I think, unfortunately, sometimes patients concentrate more on the models and freak out. So one of the things I think is really important is to make sure that patients, when they see that they score an intermediate 2 risk or high risk, that they don't internalize that median survival, because it's a median survival. It does not tell them where they actually fall. And the thing about modeling that can be very misleading is you could be a low-risk patient in August or September of 2025, and then you could jump up to intermediate 2 risk by December because of a change in blood counts or even age increasing. Yeah. So the models are imperfect. And although I was very dogmatic when I first started my career and really relied on these models, there were fewer models, I find them less helpful today. For the individual patient, generally speaking, for clinical trials, they're essential. And for transplant discussions, I think they're really key. But for the real management day-to-day of a patient, I really think it still focuses in on symptoms, spleen, and cytopenias.
Yeah, and I hear that a lot from my referring docs too. It's like, they're all, they're excited to say, oh, the DIPS or MIPS is this, but they're very quick to say, hey, this patient was symptomatic, so I started a JAK inhibitor X or Y. And I think that's really important. I think the community docs really got their finger on the pulse with this.
Because you can find low-risk patients by any of these scoring risks that feel really unwell. Yeah. And I wouldn't not treat them with a JAK inhibitor, for example, just because they're low risk, waiting for them to get sicker to treat them, which doesn't really make a lot of sense.
I mean, really the only connection there is that these models sometimes include night sweats fevers
Right.
or weight loss, right? But a spleen size of 15 isn't in there. Early satiety isn't in there. Bone pain is not in
Right.
these prognostic models, and there's really a disconnect between the two. All right, so some more social listening. After a few months on ruxolitinib, my spleen shrank and my appetite came back. But now I'm anemic and transfusion dependent. It's like trading one issue for another. When you hear that, John, what kind of comes to mind?
So I think for some patients, this can be an issue. One of the things, particularly with ruxolitinib, I would say, is it's our first and still in many ways our best-in-class agent that clearly improves the majority of patients in terms of their symptom burden and their spleen. But there are patients who are going to be more vulnerable to the on-target JAK inhibitor effects of myelosuppression and anemia. I do want to point out that anemia is often very predictable. It naters within 2 to 3 months and usually recovers in most patients about 1 gram per deciliter below where it started. But for some patients, they do trade spleen as symptom for anemia, and that's why in a later section we'll talk about some of the other JAK inhibitors to maybe tailor those treatments accordingly.
Yeah, that's something we often deal with, trading one thing for the other. You could say that for almost any side effect, right? It made my spleen shrink and my appetite came back, but then I got headaches, right, or dizziness, and then you're kind of dealing with the consequences of those things. But I think it's really important, these drugs are not perfect. They're revolutionary. They change the care of the disease, but they're not perfect. They have their shortcomings, and at some point, they won't work for a patient anymore, and we got to think about alternative therapies and moving forward. And so, John, I'm going to hand it over to you to talk a little bit about treatment failure and impact on quality of life.
So, we know from probably at least 5 or 6 independent studies at this point that the median time to discontinuation of ruxolitinib specifically is about 2 to 3 years. And unfortunately, when patients do ultimately come off Rux, their survival tends to be poor, with a median survival of about 12 to 14 months. So there's clearly more that needs to be done. Although Rux has clearly transformed and revolutionized the way we treat our MF patients, there's still a lot more work to be done, and there are patients that have, meet criteria as defined here as treatment failure for any therapy. And that could be disease progression itself, worsening spleen, symptomatology, cytopenias, or dreaded conversion revolution to blast phase disease. Some patients just don't really get an optimal response. An optimal response, at least by clinical trial endpoints, is a 35% spleen volume reduction and a TSS 50% reduction. But you have to tailor that response to each patient. I mean, some patients have these massive spleens and they have very little reduction in their spleen with their JAK inhibitor, and that could be suboptimal response for that patient. And then some patients respond initially, but then just have increasing splenomegaly or hepatomegaly. And that's a form of disease progression and relapsing disease. And then, as we pointed out, there are some patients that really develop very significant cytopenias, whether it's anemia and transfusion dependence and being stuck in a transfusion suite, or thrombocytopenia and hemorrhagic events. I will point out, though, that there is pretty good data at this point that anemia that's therapy-related probably doesn't have exactly the same impact in terms of prognosis as anemia that's truly disease-related. So just to distinguish between the two. So this is a slide, I think, from you, right, Aaron, that you put this together.
I'll take the blame.
A nice slide, actually, because it really simplifies sort of the approach to patients with MF. If you have a low-risk patient who's asymptomatic and really doesn't have any significant anemia, and that's probably 10 to 15% of the patients you meet up front, you could just watch those patients, a watch and wait approach. Sometimes that's not a very satisfying thing to think you have a chronic progressive hematologic malignancy and we're just watching patients, but those patients could be watched. And some of those patients can have an indolent, particularly some of the lower risk CALR type patients, they can have an indolent course and not need therapeutic intervention, sometimes for years. And the other patients that we typically jump on are those patients that present with more of a bone marrow failure state. They almost look like MDS, but they don't have MDS. They don't have MDS-defining mutations or dysplasia in the bone marrow that's obvious. And those patients are typically given ESAs, luspatercept off-label, which we can talk about at some point, and danazol, a male synthetic androgen, which historically has, and these all collectively I would say have response rates somewhere between 20 and 40% of anemia response. So that means there's still a good portion of patients who have inadequate or ultimately lose response, so anemia becomes really an unmet need in MF. And then, as we've been alluding to, symptomatology and splenomegaly are addressed very, I would say, well by our 4 approved JAK inhibitors labeled here. But there are many non-JAK inhibitor approved or investigational agents, as well as actually novel JAK inhibitors in development that we are evaluating to try to do better than the current drugs that we have in place. Our third polling question, again, please join us for this question. What is your biggest challenge when selecting initial therapy for a patient with MF? Is it A, managing concurrent anemia or thrombocytopenia, B, interpreting dynamic prognostic scoring systems, C, navigating differences between JAK inhibitors, D, lack of familiarity with emerging treatment options, or E, access to multidisciplinary support? So please select the best answer for this polling question. Yeah, so not unexpectedly, the cytopenias are ranking probably the highest here. Aaron, what do you think about this one?
I think it's a good question. You could answer any of it or all of these, so it's a good thing we're forcing you to pick one answer here. But yeah, cytopenias, you really get kind of stuck with a lot of therapies. You don't want to make their cytopenias worse, expose them to the burden of anemia and transfusions or the risk of bleeding with thrombocytopenia. And really stick to that first, do no harm. And so the models we talked about may be less important, and a lot of us are pragmatic and we don't really care how they work. They just, and the mechanism of action is less important. We just want to make sure that they do work. And I like to see that folks in the room are pretty familiar with the emerging treatment options. So yeah, I really like to see that 78.5% are landing on that managing concurrent anemia and thrombocytopenia answer.
All right, so the next question, which of the following patient features would most influence your choice of treatment selection? So here you can select all that apply. Platelet counts, degree of anemia, symptom severity, spleen size, previous JAK inhibitor exposure, or none of the above. Please select all that apply. We're missing music here.
Yeah, that would be a nice touch. We just have to fill the awkward silence.
Yeah.
You got any jokes? No.
No, not appropriate ones.
So pretty even across the board there in terms of responses.
So I would have guessed before this question was launched that platelet count would have been like the most common. That typically, when you talk to docs, that typically is, I think.
You think about treatment algorithms with like pacritinib and the others.
And also just the potential for complication with thrombocytopenia and bleeding, I think, really provides a node for decision making there. All right, excellent. Is this me or you now? This is me?
Oh, yeah. I think it's you.
This is me. So a little bit about the pathophysiology of MPNs. And I think what you'll notice about today's session is it's quite interactive, or at least we're trying to be interactive and conversational about this. But I do want to point out that there are some factual stuff that we know about the fundamental themes of biology that underlie MPNs, and that's hyperactivity of the JAK-STAT signaling pathway, which is instrumental to a cascade of information that's conveyed from outside the cell through cytokine receptors like EPO receptor and MIPL, the thrombopoietin receptor, inside the cell through the JAK-STAT signaling pathway. STATs are ultimately proteins that dimerize and then enter the nucleus and regulate the transcription of multiple gene sets, mainly inflammatory genes and cytokines, but also proliferative genes that govern the cell cycle. And it's been well known now for 20 years at least that this pathway through various nodes is activated and contributes to the biology. It may not be the sole aspect, but it's obviously a major contributor to the disease. And with that comes the advent of 4 JAK inhibitors that are approved and available in the US. Ruxolitinib in 2011, based on the COMFORT studies, very effective drug, particularly upfront in reducing spleen and symptom. And of course, we did mention the on-target cytopenias that can occur. Fedratinib as a very potent JAK2, FLT3 inhibitor, approved in 2019, and off the Jakarta-2, often used as a second-line agent to address spleen and symptom where patients may not have had that response or lost the initial response with ruxolitinib. You know, I'll point out Wernicke's encephalopathy is the only black box warning we have with these drugs, thiamine deficiency, so checking a thiamine level, vitamin B1, and repleting usually addresses that issue. I rarely have that as an issue. And understanding that the FLT3 inhibitors for mechanisms that I don't know why are associated with GI toxicity. So we see with fedratinib and with pacritinib more nausea, vomiting, and diarrhea, but these are easy to manage issues with antiemetics, which occur in about 50% of patients, usually in the first 2 months. And if you warn the patients that this could happen and give them access to ondansetron or antiemetic and antidiarrheal when needed, they're very easy to overcome. And I always want to stress that it really only leads to discontinuation in a very small percentage of patients. Pacritinib is different, I would say, than some of these other drugs in the sense that it is a JAK2 inhibitor, so it shares that biology. It completely eliminates JAK1, which is of interest and may have effects on stem cell function and platelet production. But it's an IRAK1 inhibitor. In fact, I've often thought of it more as an IRAK1 inhibitor than it is a JAK2 inhibitor. And it decreases the pathway of toll-like receptor IRAKs, which are a series of proteins, all the way down to NF-kappa B, another transcription factor that also is upregulated in MF and governs the inflammatory cascades and a lot of the symptomatology and biology that we see in myelofibrosis. So it's a non-redundant pathway that complements JAK-STAT signaling inhibition. And what sets pacritinib apart, I would say, from the earlier ruxolitinib and fedratinib therapies is less myelosuppression. So it was developed and ultimately approved as for patients with severe thrombocytopenia less than 50,000 with data for greater than 50,000. And then momelotinib, approved in September of 2023, sort of fills it out, really trying to address the anemia aspect because both momelotinib and pacritinib are ACVR1 inhibitors. So momelotinib is an equipotent JAK1/2 inhibitor, much like ruxolitinib, but also has ACVR1 inhibition, which is important for hepcidin production. And hepcidin is an important regulator of iron availability through the ferroportin channels. So this drug has been associated with less anemia and even better transfusion independence than the other drugs have, which can also be seen with pacritinib to some extent in the lower platelets. So there are niches for these drugs. It makes it a little bit more complicated, but it provides us with opportunities to tailor the therapy and even sequence the therapy after the failure of one JAK inhibitor. But it doesn't stop there. There's a lot of clinical investigation that Aaron and I and many others are involved in. Here is one schematic that gives a sort of a broad sense of where the field is right now from a clinical trials perspective. I will point out some therapies that I think are really interesting that are furthest along, therapies like MDM2 inhibitors, navtemadlin. What's gotten a lot of attention very recently are the mutant CALR directed antibodies like the Insight 33989, in which we've presented data in ET and we'll present data in MF shortly, that may have the opportunity to have the first molecularly defined therapeutic approach for patients with these diseases. Imetelstat, the telomerase inhibitor, approved in lower risk transfusion-dependent MDS. For anemia purposes, we are evaluating it in a large randomized phase 3 study, which has almost completed accrual for patients who failed JAK inhibitors, those patients that we know have, unfortunately, the worst potential survival with an overall survival benefit. And then, of course, up front, we're looking at therapies like selinexor, the XPO1 inhibitor approved in myeloma and other B-cell malignancies, which has rationale in this disease state as a combination with ruxolitinib versus Rux plus placebo. And then the MANIFEST-2 study, which was pelabresib, which we recently published several months ago, at 24 weeks showed improvement with this oral BET inhibitor in combination with Rux from a spleen perspective and a nominal improvement from a symptom perspective, but not statistically significant. And we continue to follow these patients out. And I think one of the things we've learned as a field is that for us to introduce combination therapies, we really need to prove that the combination therapies are providing significant and meaningful improvements above what the JAK inhibitors. And you'll notice that almost all of these therapies, when in combination or in combination with ruxolitinib as a treatment approach. But the onus is on us as clinical investigators in the community to demonstrate that we're not just shrinking spleens more, which we think has value, but improving symptoms, and that can be difficult because there's a ceiling in which you can improve symptomatology, but looking at other disease-modifying aspects, and that's a whole topic in itself. So here are some of the recently completed MF therapies. The one study that I will definitely highlight here is the independent study. This is a study with luspatercept, a drug that is approved in lower-risk transfusion-dependent MDS patients, now even upfront in patients who haven't even seen an ESA based off the COMMAND study. And this is an easy drug to give every 3 weeks as a sub-Q injection, much like an ESA, but this is an EMA, an erythropoiesis maturation agent, inhibiting TGF-beta superfamily members called activins that have demonstrated the improvement in anemia that actually Aaron led the original study, the phase 2 study, in 30% transfusion independence with ruxolitinib, which is not a small feat, and 50% reduction in 50% transfusion burden, which is also clinically, I think, relevant and important for patients. And the independent study just very recently had top-line data at a press release in which we are very anxious to see some more of the granular data because I use that frequently in the clinic off-label to address anemia. And I wonder, Aaron, you've really been at the forefront of this aspect. What do you think?
Yeah, I mean, I think it's another important tool for all the reasons you mentioned. And I'll also add that its use is endorsed by the NCCN guidelines based on the phase 2 data. Even before the independence trial read out. And if you look at the press release, you will see too, though, that there are secondary endpoints that were met. And I think that's a key piece of what we'll see when the data comes out and we take a closer look at things. Myelofibrosis, myelofibrosis-associated anemia is not just a singular pathobiology. There's multiple factors leading to one individual's anemia. And so having just one drug to treat anemia isn't going to be enough. And so we need drugs like luspatercept and other drugs that are being developed to treat anemia and myelofibrosis, actually to take the best care of our patients. Again, you mentioned response rates for these agents are 20, 30, 40%, somewhere in that range. It's not 100% every time. And so I think it's really important that we continue to push these things forward.
Absolutely. I won't talk about navitoclax, which is a cousin of venetoclax used in our AML patients, but this is really a rational therapy that unfortunately failed. I think more of a consequence of study design than activity of the drug. And then here is a list of agents that I think Aaron and I would agree are furthest in clinical development and most likely to emerge, if one were to emerge, as a commercial agent, whether it's, again, imetelstat in the IMPACT-MF as a single monotherapy after relapse refractory disease from a JAK inhibitor. We continue to follow the pelabresib pan-BET inhibitor treated patients in combo with Rux for progression-free and overall survival, and obviously an important endpoint. The selinexor study, the Karyopharm phase 3 study, just literally today completed enrollment. So we are hoping that by Q1, Q2 of next year, we'll start to see some of those results come out, and that will be exciting. That's a very rational agent as well. I think one of the most potent agents we've seen in the field is navtemadlin, an oral MDM2 inhibitor that has very significant clinical activity and is based on the fact that MDM2 is upregulated in MF CD34 cells and governs wild-type P53 activity. Navtemadlin turns on the P53 pathway, thereby inducing cell senescence and apoptosis in the lab, and clinically is very active in terms of spleen symptom and reduction in biomarkers of disease modification, which Aaron and I love to talk about, which is very vague, but would suggest that reduction in bone marrow fibrosis, driver mutation allele burden, and circulating CD34 cells are aspects that we try to capture in these studies as surrogates for actually modifying the clone and ultimately the progression of the disease. The Boreas study is the first study. This is a monotherapy relapse refractory. We presented it at ASH 2024, showing improvement in spleen and symptom burden over BAT, best available therapy. And then the Poesis study is the ongoing, very innovative study, taking Rux-naive patients and then randomizing them after they've received about 16 to 18 weeks of Rux. And those that have a suboptimal response are then randomized to either getting placebo or the addition of navtemadlin onto their stable dose of ruxolitinib. So it's an interesting trial design because I think it actually mimics in many ways what actually happens in the community practice. We're back to our panel discussions. When a patient has anemia, thrombocytopenia, or both, how do you tailor JAK inhibitor choice and dose in practice? That's for you, Aaron.
Oh, that's a great question with a lot of answers, right? So there's the challenge is not those patients who have platelet counts that are above 100 or those with platelet counts below 50,000. It's the in between, right, where all the JAK inhibitors have some data. And how do you select at that point? Well, I think certainly the anemia helps drive that. Momelotinib and pacritinib both showing some anemia benefit, both in prospective and retrospective manners. And so you kind of narrow in on those two, and then you're looking at other things like maybe side effects, right? So prolonged QTC with pacritinib, you may steer away from that. Or momelotinib, if you have a person who has maybe some GI distress at baseline, you might want to steer away from that. So really, you kind of start looking at side effect profiles, but I think both are appropriate. And I think the most important thing is if you choose one, it doesn't mean you can't choose the other, right? You try momelotinib in this situation. If it works, great, you go with it. If it doesn't work, you can switch to pacritinib, right? It's not a one-way valve. And so you have that flexibility, that safety net. So, and you don't want to be paralyzed by inactivity. Choose a JAK inhibitor, use it, see if there's benefit. If not, move on to something else.
But at least give it 3 months, I would
yeah.
say, right? Like don't jump off of it too quickly because you might not actually get the actual benefit of the drug. How do you communicate risk-benefit trade-offs with patients when dose adjustments are needed? So like I think like this kind of speaks to the cytopenias and the R6.
Yeah, I think you got to trade that off, right? All the data tells us that maximal JAK inhibition is important, right? You're getting the full dose in, you're getting that maximal JAK inhibitor, you're shrinking spleens, making symptoms better, but patients are actually living longer as a result. And so if you do run into a side effect, is it something that's going to be temporary, that if you kind of get over the hump, is it a nausea or a diarrhea where you can get over the hump and continue on that maximal therapy, or is it something that's going to be really limiting? Is it an anemia that you're never going to be able to get the dose back up from? And I think that's really the question in my mind. Is this something that's just a temporary thing that we can get past, or is this going to be long-term that does indicate a change in therapy?
And then, maybe for the sake of time, I'll ask you this very pointed last question. Are there any of the trials that are going on or therapies that are in development, anything that particularly you think is interesting or stands out?
Oh, boy. It's like choosing a child, right? They're all my favorite. That's hard to say. I think some of the stuff that's really kind of different, I find the most interesting. Stuff like the calreticulin-directed therapies, especially when you start talking about bispecific antibodies and CAR T cells. I mean, that's just wild to imagine, right? And the fact that we're seeing this enter the clinic is just totally mind-blowing. So I find stuff like that really compelling because it's just a different way of doing things.
Yep. I agree. And I think we often say, or at least I often say, we don't really have room for more JAK inhibitors, but we actually have 2 JAK inhibitors in clinical development that I think are really fascinating. Type 2 JAK2 inhibitor from Ajax, and then the JAK2 V617F selective inhibitor from Incyte. So there are interesting, I think, evolution.
I think this was me. Yep, yeah. So as we enter this age of combination therapies, we really kind of recognize this polarity of monotherapy versus combination therapy. And we got to find a balance between the efficacy, the durability, response, toxicity, and the cost of the treatment, right? So clearly 2 drugs are going to cost more than 1, and that's going to be an important part of treatment selection for these patients. There are lots of diseases. I'm going to pick on Dr. Corey there, in multiple myeloma. You can give like 16 drugs at once and cause these major molecular remissions, but is that value, right? And so I think now that we're in the age of combinations for myelofibrosis, we're asking ourselves a lot of the same questions because we don't know what the best is. We don't know, is the best, a JAK inhibitor followed by a JAK inhibitor followed by a JAK inhibitor, or is it a JAK inhibitor with a new therapy at the time of inadequate treatment? Or do we start at the beginning, right? And treatment, studies like the navtemadlin study, where it is kind of this logical sequencing. You start someone on an individual agent, then you add on combination at the time of an inadequate response. Really, I think is the first step at trying to address the best sequencing. I think it's thrilling to be in an era where we're talking about sequencing. It makes us feel like we're part of the club in hematologic malignancy. We're not just a one-trick pony with just JAK inhibitors. So I do think this is very exciting. I really am absolutely amazed at where the field has gone and where we might go in the very near future. But we are now starting to struggle with the same problems that many of the other diseases do with multiple agents. How do we sequence? How do we combine? And what's the best way forward? Not just for standard outcomes like SVR35, TSS50, but for survival and value and quality of life. So pivoting back to the patient, here's another social listening. My mother-in-law more recently progressed to myelofibrosis, and either the disease progression or medication is creating a lot of bone pain. I believe a lot of fatigue too. It seems like there is a lot of conflicting information. Is this something where her disease and symptoms will only continue to get worse, or if she slows down and takes it easy, will she be able to feel better? I'm trying to figure out what that balance is. And I know this is something that I hear a lot in clinic. I don't know, John, does this ring any bells for you?
Yeah, absolutely. I mean, first and foremost, I'm impressed that the person is worried about their mother-in-law. I think that's an interesting aspect in itself. But yeah, I mean, we have a lot of issues where, the symptomatology, or the fatigue particularly, could be outpacing what the counts are doing. And I think as Sheldon pointed out, which is definitely true, is sometimes there's a disconnect between what we see in the labs and how the patient's feeling and doing. And the patient can really feel terrible and their labs may not reflect it, or vice versa. They could be in the transfusion suite sometimes and their hemoglobin's lower, but maybe on a JAK inhibitor, they're actually feeling better and performing better. So it really is complex because it doesn't always line up neatly. And there sometimes is challenge in trying to figure out like what is disease related versus what could be toxicity from a therapy. I think there is a tendency for some patients just to think that everything that's happening is drug related. So I think education and going over with the patient's symptomatology and what could or could not be drug related is important.
We got some questions.
So we do have some questions from the audience that we would like to cover. So here are, I guess, 4 questions that were randomly picked from the audience. Actually, very good handwriting. How should community clinicians prepare now for integrating these new agents into practice once approved? That's a great question, and a really hard question to answer. So, we have, and I think Aaron would agree, I mean, I think we interact with a lot of community physicians, and the reality is myelofibrosis is a community diagnosis. It's a diagnosis 2/3 of which are treated in the community. They're not really treated by people in academic centers. And how to move from a paradigm where we're really just JAK inhibitor focused and have these 4 JAK inhibitors, when to use them, when to move on to them, that's difficult in itself. When to diagnose failure on one of these drugs. How to now integrate new drugs, I think, is going to be challenging. Like, does every patient deserve a combination up front if a combination looks good? Or like the poesis approach, like treating the patient and then maybe adding the second agent on to recapture spleen or symptom benefit might be better for other patients. So I think the reality is we're probably going to have hopefully a number of drugs that are approved, and more drugs, more opportunity to personalize the therapeutic approach, but it will make it more complicated. So we'll have to have another symposium next year to do something like this. And how to integrate them, I think, is really going to be confusing. So I do think it's going to require some degree of education, not just for us, but for everyone involved.
And I think we saw that with just the JAK inhibitors alone. As they became approved and introduced to everyday practice, there was a learning curve. We had to introduce, like, how do we sequence these and how do we use these in different populations. And so I think it'll be, as you said, even more complicated with combination therapies as they do emerge. It puts the onus on us as educators. Again, it's self-sustaining here in terms of these symposia, but I think it's really exciting to think about this, right? You think 10 years ago there was 1 drug, right? And now there are 4, and who knows what the future will hold. So it's very exciting times, and I think it's a problem we all want to have. All right, so the other questions are very similar. As more therapies become available, how do you anticipate the quality of life considerations, including treatment decisions, along with the data? How do you strike that balance?
Well, I mean, I think that's going to be key from the trials, is we want to make sure that we're not at the risk of ruining quality of life and adding toxicity, that we're addressing the disease appropriately. That was one of the things I liked about the MANIFEST-2 study with pelabresib. If you look at the toxicity curves there, they actually look very similar. Mm-hmm. Like, we didn't actually add meaningful or significant toxicity, treatment-emergent toxicity with the addition of pelabresib. So I think it's really going to be key that whatever effect we're in obtaining with the combination, that it's not offset by worsening cytopenias or symptomatology. So, I recognize time is of the essence here, and I want to make sure that we get everyone to their next meeting as well. So I'm going to stress one more time. If you haven't already done it, please fill out the pre-test questionnaire and then the post-test questionnaire, because that really helps us understand if we were on target. It helps us develop future education. And if you're interested in CME, the evaluation is also here. It should be at your table, as well as access, as Aaron pointed out, to all the slides and the educational points with the QR code as well. So I want to sincerely thank everyone for joining us today. I want to really thank Aaron for co-hosting this event, and I hope everyone found it to be educational and informative. Thank you.